Actualmente, como siempre decimos, estas sesiones es buscando personas, buscando profesionales que aporten una visión personal y valor a áreas, habitualmente de la cardiología, que tengan un interés global para todos. Hoy realmente este objetivo se cumple especialmente. Hoy está con nosotros por primera vez, yo creo que aquí en el Hospital Clínico Universitario, en cardiología, Cristina Gavina. Cristina Gavina es sin duda una de las cardiólogas más relevantes de Portugal y a nivel europeo. Es la presidenta electa de la Sociedad Portuguesa de Cardiología. Es una autoridad en el ámbito de lo que hoy nos va a hablar, que es un poco algo que nos afecta a todos y que afecta a pacientes en el día a día, como es la estrategia antitrombótica en pacientes con síndrome coronario agudo y más allá del síndrome coronario agudo, un poco a largo plazo. Veréis que realmente la presentación es una presentación fantástica, con mucha traslacionalidad práctica al día a día de lo que hacemos cada uno y bueno, lo que os comentaba, realmente es un privilegio que alguien como Cristina esté hoy aquí con nosotros. Yo tengo la fortuna de conocerla desde hace ya un tiempo y de tener una amistad personal con Cristina. Por tanto, para mí en concreto es especialmente satisfactorio que esté aquí con nosotros en el Hospital Universitario, en el Servicio de Cardiología, y que pueda visitarnos y que podamos de alguna forma desarrollar algún tipo de proyectos. Ella es la responsable de cardiología en el Hospital Pedro Hispano de Matosinhos. Tiene una formación previa y sobre todo tiene una formación muy amplia en investigación clínica. Ha hecho estancias fuera y sobre todo un programa de formación muy exclusivo en Oxford sobre planteamiento de la investigación clínica, donde es una prioridad. Es decir, nosotros tenemos casi una obligación, todos los profesionales tenemos una obligación real, más allá de ética y lo que queramos comprometernos, con generar algo de conocimiento. No podemos esperar que investiguen otros y que nosotros vengamos aquí a hacer un trabajo que, si no investiga, el centro que no investiga, la atención se resiente de forma inmediata. No hay que esperar, se resiente de forma inmediata la calidad de la asistencia y Cristina en realidad es ese liderazgo que ella ejerce también dentro de la estructura de la investigación clínica. Por tanto, Cristina, muy obrigado por estar aquí connosco y vamos a comenzar a tu palestra.
Bueno, empezar diciendo a todos buenos días, agradecer a João el convite y deciros que no voy a intentar hablar en portuñol, que voy a hablar en inglés porque es mejor para todos nosotros, ¿vale? So it is actually an honor to be here. This is one of the places that I've heard about a lot, about the quality of this kind of meetings. And I know that you have actually a state-of-the-art cardiology department. And it is actually an honor that João has invited me to be here with you and to be able to share some of my views, personal views, as he said, about antithrombotic strategies. So let me tell you a little bit about me. So I'm a clinical cardiologist, okay? I'm in the bottom of the pyramid. So I was starting first in the CCU, and afterwards I started getting a wider view of what was really important for cardiologists. And I remember now that at first I thought that the very special things would be very, very important. And then I started realizing that probably it is important to have a big picture so that you can get to more people and be able to intervene more. So this is my view on how we should also look at cardiology. So not everyone has to be interventional cardiologist or electrophysiologist. You can be a clinical cardiology and make a difference in people's lives. So antithrombotic strategies are actually very interesting to me because I started in the CCU, as you can imagine. And at first, we had this idea, of course, that the mainstream of everything that happens in ACS is actually antithrombotic therapy. That's the one that's going to make you do things and be able to do intervention and prevention. So it's really, really important. And the world has been changing a lot. So as you can see, this is probably the most studied area in cardiology. And this is fascinating. I mean, no one else in any other area has as many studies as we do in antithrombotics. So you study everything, the timing, the duration, if you should prolong, shortened, and everything can be focused either on the ischemic risk or the bleeding risk. And if you look at here, you can see that the ischemic risk was the one that drove all these studies. And then the bleeding risk was the one that actually started to be very important in some point when we shift the idea of the ischemic risk being the most important one, and we started actually acknowledging that probably bleeding would also have an impact in these patients. And when we look at what is the guidelines, and I'm not going into anticoagulation and atrial fibrillation because this is another world, but if you look at the guidelines, things are quite complicated nowadays. So those were the days when we just had to do aspirin and clopidogrel and that was it. But nowadays you have several strategies that you can do. Actually, they divide patients into low, high, and very high bleeding risk. And then you have a lot of options, of course, that prasugrel and ticagrelor are the ones that you should prefer. And then you have clopidogrel and you can do 12 months. This is the common strategy. But then you can have also the combination with ticagrelor for 3 months and then just go on monotherapy with ticagrelor. And then you have these other combinations that are actually shortening the time of dual antiplatelet therapy and trying to be less intensive, using either aspirin for those at high risk or clopidogrel for those at very, very high risk. So this is also always a balance between the bleeding and ischemic risk. And the big problem is that the patient, the same characteristics that put him at high risk of thrombosis are also the same that put him at high risk of bleeding. And everyone knows this is the default strategy. You should use aspirin and a P2Y12 inhibitor, and then you should do it for 12 months. But we started with this, the idea of intensification. So we wanted to have powerful antiplatelet agents, and we tried even for triple therapies. And then we started changing this idea and trying to figure out what was the right duration. And you have those that were going for the short-term duration and those that were prolonging duration. And then we started with de-escalation. So we started figuring out if we had to have all this potency at first and then try to de-escalate to try to diminish the bleeding risk. And we're going to figure out in each of these what were the things that worked and the things that didn't work. So starting with dual antiplatelet therapy. When we started with this, we thought, well, this is not enough. Probably if we add something else, because there is always a residual risk, we could add something. And then you go for the phase 2 studies and everything seems to work perfectly. I mean, it's like for Apexar. It didn't increase bleeding. It seemed wonderful. So we went for a triple therapy. Nowadays, of course, because of the anticoagulation experience, we know that triple is always worse, whatever triple you are thinking about. But with Vorapexar, we learned it in the worst way. because there was actually in chronic coronary syndromes a trial that increased intracranial bleeding, and the TRACER trial was stopped because of that. So we didn't go that way. So thrombin inhibition could be a good thing for patients, but it increased risk too much, probably because this shouldn't be triple therapy, but that's another discussion. And then we thought, well, maybe anticoagulation in a very low dose can work. And that's why rivaroxaban in 2.5 was also added in SES. And you know the story. The problem was that the ATLAS trial was a good trial. It even decreases cardiovascular mortality, but it had some problems also with the patients that were lost to follow-up, which made FDA really nervous. And also it had that tendency to increase intracranial bleeding, and it's a very major increase also in major bleeding. So probably this is not the right answer also. There was probably too much of a bleeding risk there. And now we have asundexian. As you know, this is a new agent, anticoagulation. It's anti-11A, and we thought that 11A was going to be, and probably is going to be, at least in stroke, the next big thing. So anticoagulating without having an impact on the possibility of having hemostasis. So it's an anticoagulation agent, but it wouldn't have as much bleeding as we thought it would, because when people genetically have this kind of lack of anti-11A, actually they don't bleed that much. So asundexian has been tested in a phase 2 trial. It has been presented in the last ASC, but in MI, it didn't seem to work that much because it didn't actually had a bleeding difference between these two arms, and it didn't have any hint of benefit in terms of ischemic events. Of course, we're going to be having a phase 3 trial, but I'm not sure if this is the way to go, and the dosage is clearly not resolved yet. And then you have the traditional thing about dual antiplatelet therapy, and of course, intensification with prasugrel or ticagrelor seemed a wonderful idea. We also have more bleeding, especially spontaneous bleeding. They were tested in different settings. We know that prasugrel was with no preload. It was in patients that were undergoing intervention, and it worked. It is good, but you have to be aware of patients with previous intracranial hemorrhage and also patients with low weight or more than 75. And for those, probably you have to do dose adjustment or not use it at all. And then you have ticagrelor, which had one wonderful trial, which is a Plato trial that actually reduced cardiovascular mortality, but it didn't get to do the same in other trials they started doing in other contexts. It didn't work as well. So there was always a little bit of probably a chance there that they could have a very good result in those contexts. But the truth is, most of us are using aspirin with ticagrelor. And then, of course, you have clopidogrel, which was the one that started first. I remember that when I started my residency, this is the strategy we were doing, and it was really, really great. I mean, we had ticlopidin before, and at first, when I started, it wasn't yet available in Portugal, so we started doing 1 month of clopidogrel, which is offered by the company, and then we went for ticlopidin. So you can imagine how old I am. These were the days. And now, what I find more interesting is that suddenly we have a class 2A indication for using prasugrel instead of ticagrelor based on a study that probably, if all of you would look at it very carefully, would never thought that the ESC would have this kind of guidelines. I mean, of course, everyone wanted to test head-to-head prasugrel or ticagrelor. It seems it's the natural study. So we tried. Prague 18 was a trial that tried to do this head-to-head comparison, and actually they stopped for futility. But then you have ISA-REACT 5, and ISA-REACT 5 is a great study in terms of concept. Of course, you should try it. It's a pragmatic trial, but it is an open label trial. And of course, you may be, thinking that probably open label is not enough to be a bad trial. It's true. But if you think that about 20% of the patients that were discharged were not discharged on their allocated medication. And if you think that many of these patients, the ascertainment of their events was done by phone and not by anyone actually looking at their files and seeing if those were actually the events. And if you think that most of the patients that were actually discontinuing, as we also expected, were in the ticagrelor arm, mostly because of dyspnea, you can understand that this isn't a balanced trial. So probably we should have here a class 2B and not a class 2A for having a preference for prasugrel over ticagrelor. But again, this is what is in the guidelines, but I think we have to be a little critic here. And then we have the problem of duration. So short duration, long duration, and what kind of short duration? Are we going to drop aspirin or are we going to drop the P2Y12 inhibitor? And of course, again, trials were oriented in different ways. So if you were looking for selling medications, then you're going for the long-term duration because that's the purpose of the company. But if you are thinking about the stent, what you want to prove is that you can do shorter duration of antiplatelet therapy. Because the thing is that if you do that, the stent is really good. It's not going to increase stent thrombosis. So people were actually trying to figure out if they could or diminish the time of anti-aggregation or augment it. Well, whatever was their actually most concerned. And prolonging, of course, is going to diminish what is the ischemic event. That's what we know. We know that that can happen. But the problem is you're always paying with major bleeding. So you have to figure out what are really the patients that can benefit. And this is happening because many of these patients are going to be in high bleeding risk. This is 40% of all PCI patients, not just ACS patients, but PCI patients are thought to be on high bleeding risk. And that makes us realize that we're going to have this problem many, many times, probably most of the times, and we don't consider that. And bleeding has a toll, so you have to pay for it. And most of the payment is going to come at first, when you have the bleeding in the first month. And of course, we know why. They're not going to die because of bleeding, because we can always give them blood and do everything to keep them alive, resuscitate them. But the thing is that they're going to stop the antiplatelets. And when they do it, they're going to have events, and it's going to be the ischemic event that's going to kill the patient. So this is really important, thinking that bleeding is not a small thing. It's going to be as important probably as an ischemic event. And we know all these risk factors and all these scores. I have to say that I hate scores because I think they don't help us at all. You're not going to be using every time your app to try to figure out what are the scores. But in a general way, if the patient is anemic or the patient has had a blood transfusion or has some condition that actually put him at higher risk of bleeding and you cannot do anything to change it, then probably you shouldn't be going for the most aggressive strategy. And again, what has happened in the long term in patients with ACS? Most of the ischemic risk is going to be concentrated in that first month, and then it diminishes. But that doesn't happen with the bleeding risk. The bleeding risk is accruing. So the bleeding risk is going to keep on going, the same bleeding risk during all this time. So we have to be more concerned with the bleeding risk after this more unstable and more thrombotic phase, which is the first month. So it makes sense to try to figure out if there are ways that you can target these high bleeding risk patients and start doing a shortened duration for those. And MasterDAPT was a trial, also pragmatic, big trial, that tried to figure out if that could help. And then you have just 1 month of DAPT, and then you would have 5 months for the prolongation of DAPT, or you wouldn't do any DAPT and just one anti-aggregate. So you have to imagine that for those at high risk, what is recommended, very high risk of bleeding, what is recommended is just 1 month, and then you should be continuing if you think they don't have that higher risk at 6 months. And the interesting thing is that this was, of course, not targeting especially the patients with ACS. It was the overall view. But if you looked at the patients at ACS, they had the same benefit we found in the overall trial in reducing those that were the bleeding risks, so the bark bleeding, and without paying for an increase in ischemic events. And this is really important. And you have to see that most of those that were doing single antiplatelet were actually doing either clopidogrel or ticagrelor. So mostly clopidogrel, of course, but this is important because this is a setting where probably we start thinking that dropping aspirin can be an important thing. And again, most of this discontinuation and shortening are happening with prolonging with aspirin. So you have several trials that drop the P2Y12 inhibitor, and just most of them were not done in the ACS setting when we know that thrombotic risk is higher, and that's where the real discussion about shortening is happening. But there were 3 trials that actually did it. And what did we find? First of all, most of them are going to look for non-inferiority. And then you have to think, what is the non-inferiority margin? And this is really important, because if you look at the first trial, the SMART-8, you were actually thinking that non-inferior would be something that could actually increase the ischemic risk by 66%. I mean, what is non-inferiority here? You have to look at it and try to figure if that's the thing you want to pay to diminish bleeding. This is really too much. And in the other 2 trials, which are actually small trials, there was a hint of an increase in ischemic risk. So probably when you're starting the prolongation with only aspirin, probably things don't go as well as you want. And that's why people are actually thinking about, why not dropping aspirin? I mean, we started to have this very good experiences in other settings, even in oral anticoagulation, dropping aspirin when we're doing triple therapy after a PCI. And we started also looking at it and thinking, well, maybe bleeding is coming from aspirin. And we know that this is dose dependent. And maybe with the good therapies that now we have and the very small event rates that we have actually in trials doing the best medical therapy, we don't need aspirin anymore. And so all these other trials were performed to try to drop aspirin instead of dropping the P2Y12 inhibitors. And these are quite interesting because you had strategies for just 1 month or 3 months. And here you have the 2 big trials, which are the global leaders and Twilight. And then they prolonged, especially these 2 trials, prolonged with ticagrelor. So this was the monotherapy with ticagrelor, either after 1 month or 3 months. And then you had some that prolonged with any type of P2Y12 inhibitor, but these were actually the smaller trials and in Asian population. And of course, we have the problem that most of them were open label, but Twilight was actually double-blinded. And looking at global leaders, this is a really interesting thing because it's driven by the investigator. It is a good idea. Of course, we wouldn't go for this primary endpoint of composite of all-cause death and new Q waves infarction. Nowadays, we wouldn't do it, but at the time, it seemed to be helpful for them because of the adjudication of events. And they had actually a lower rate of events than what they expected. And what they showed was that there was actually no difference in terms of MACE, and this primary endpoint. Of course, that they were really not that smart because they prolonged it for 2 years. And if you went to 1 year, which is where the most of the thrombotic risk is, probably they would get a positive trial, but this is what it got. And the bleeding was actually the same. With Twilight, they actually pushed in patients that had very high thrombotic risk, so very complex PCIs and high thrombotic risk. They tried to see if they could actually, with a prolongation, with only ticagrelor, they could lower the risk of bleeding, and they did. It did lower it very well, and they had no increase or any hint of increase of any of those composites of ischemic events. And truth is that either you were looking at patients that also had non-STEMI, and we have to realize that STEMI were excluded here, then that can be a problem. You always find a benefit in terms of diminishing the risk of bleeding, but without paying anything for ischemic events. And the same thing happened with TICO trial, which is a smaller trial, of course, but it had the same kind of results. And it seems like ticagrelor in this combined endpoint with MACE and bleeding was better. So when you put it all together and you go and look at the subgroup of patients and global leaders that had adjudicated their events, actually, and the ones that were in the twilight, you can see that actually you have always a decrease of bleeding, whatever classification you're using, and you don't have an increase in mortality or an increase in ischemic events. And this is happening, either you combine it with global leaders or with TICO or twilight, and it's always the same type of hint. And the important thing is that this is translating into a reduction in all-cause mortality. So this is the overall picture that we have now. Of course, that there are other aspirin-free strategies that are going on. A lot of trials are going to be coming soon, and most of them are going to have ticagrelor as monotherapy. So we're probably going to have more evidence than a two-way evidence that we have now in the guidelines. And finally, we have de-escalation. De-escalation is actually a very good idea. I mean, if you don't need as much intensity of antithrombotic therapy after the first month, probably you should actually not keep on going with the most potent P2Y12 inhibitors. So it makes sense. And then we can do it either unguided, so you do it for everyone, or you can do it guided, which means that you're going to have to do any platelet reactivity tests or genetics to find out those that have these mutations that put them at higher risk because of clopidogrel not being as effective as we want it to be. And then you have these two different strategies that for chronic coronary syndrome, some people are using this kind of tests to escalate, which means they're doing aspirin and clopidogrel, and they're doing the tests to try to find out those that have actually this very high reactivity of the platelets under clopidogrel. And you have the ones in acute coronary syndromes where we're trying to de-escalate and bring them down from prasugrel or ticagrelor to clopidogrel. So these de-escalation techniques are actually still a 2B class indication, and there are several ways you can do it. So these are the ones with unguided escalation, so you do it for everyone, and you do for a short time prasugrel or ticagrelor, and then you stop it, and you're going for aspirin with clopidogrel, and these are also non-inferiority trials. So what we're trying to achieve here is to show that you can reduce bleeding without increasing ischemic events, and they work. And when you look at the guided escalation, either with a reactivity test or with a genetic test, you also have a positive endpoint, which is the combination of bleeding and ischemic events, and again, non-inferiority, as I said. And this comes to this. So we have balanced events in terms of with a decrease of bleeding that drives actually the endpoint. And it seems to be similar in terms of the de-escalation with either techniques. But several questions remain. I mean, what's the right form? Would you do prasugrel 5? Would you do ticagrelor 60? So you're going to de-escalate to what? 90 ticagrelor, 60 ticagrelor? No one knows. Should it be guided or unguided? So unguided is much easier, of course. Should we do it at the first day, from the first day, or should we do it later on? And that's an open thing, because right now the de-escalation has been done unguided after 1 month, and the ones that were guided were actually performed at 1 to 14 days. So there are a lot of trials again going on, trying to find out which is the right dosage and which is the right form of de-escalation. And there are even meta-analysis, this network meta-analysis, which I actually hate, trying to do indirect comparisons between these trials and showing that probably you could favor de-escalation in terms of decreasing the ischemic events. And if you want to decrease the bleeding events, you should do a shorter duration of DATP and not exactly de-escalate. But what I find very interesting is that if you look at it with all these options, this is a complete nonsense. I mean, no one can remember ever this kind of thing. So you have this the strategy possible here with short duration of DAPT and discontinuation with P2Y12 inhibitors and prolongation of aspirin. You have these several strategies, and then again with high bleeding risks and those with de-escalation. So this is completely impossible. No one can ever remember this when they have a particular patient in front of them. So I would say that what we need is a dynamic evaluation. So we have to, bleeding risk should be first. You have to figure out the patient you have, is he or not a high bleeding risk patient? And if he is a high bleeding risk, you know you're not going to prolong, that's for sure. You're not going to for over 12 months. So that's decided. And probably for those, you want clopidogrel. You don't want a more powerful P2Y12 inhibitor. And then you have to evaluate ischemic risks. And if the ischemic risk is high, probably you should consider using one of these most potent agents. And if these are only moderate risk, probably you should go for a single antiplatelet after those 3 months of dual antiplatelet therapy and continue with ticagrelor. But if they're really high risk of thrombosis and low risk of bleeding, probably the 12 months would be the way to go. And of course, you can even have these other strategies of prolongation with the dual pathway using rivaroxaban for some special patients, namely patients with polyvascular disease. So we should come from this kind of scheme to something like this, which would be much, much simpler. I mean, probably the default strategy should be only having 3 months of dual antiplatelet therapy and then prolong with ticagrelor, because this is the one that has most of the evidence. It's not prolonging with aspirin that has most of the evidence, it's actually prolonging just with ticagrelor. And then for the very high risk, we should do just 1 month of dual antiplatelet therapy with clopidogrel and then prolong with clopidogrel. So these are my golden rules. Sometimes, and most of the times, less is more. So we learned this with anticoagulation. This is also true with antiplatelets. But please keep it simple, because if this is going to be as complex as that table I showed you, we're not going to do the good job that we have to do with our patients. Thank you for your attention.
Fascinating and stimulating talk. A really very interesting issue about personalized medicine, not only in acute coronary syndrome, but also in intervention cardiologists and probably beyond, because other clinical scenarios is needed to personalize the antithrombotic therapy. So we can start. Podemos hablar.
Sí, podemos hablar en lo que quieras.
Sí. Y como en Portugal nunca se sabe muy bien qué falar, ou tal, en galego portugués, que
Pero
casi é
hablas
moito.
muy bien portugués. Verdad,
Acho que
verdad.
non, mas... Pues podemos comenzar, yo creo que es un área, como decía, fascinante. Cómo personalizar. Es claro que cada vez más el riesgo hemorrágico se impone. Aquí la clave es definir el riesgo hemorrágico, no tanto el riesgo isquémico. Yo creo que, y las nuevas recomendaciones de STEMI que salen ahora en agosto van en esa dirección, de que aquí lo importante es definir a los pacientes que pueden sangrar, porque si sangran es una catástrofe. Es una catástrofe por el sangrado y es una catástrofe de qué tenemos que hacer con lo que le protege. Y especialmente es una catástrofe en los 3 primeros meses. Luego, quizás un poco menos, ¿no? Por eso yo creo que la definición del riesgo hemorrágico es crítico en este momento. Debe guiar todo lo que vamos a hacer en función del riesgo hemorrágico, porque lo que tenemos que evitar, sobre todo, es que el paciente sangre antes que nada.
Porque va a suspender toda la...
Claro. No solo las consecuencias del sangrado, el problema si lo tienes que transfundir de la sangre conservada, pero eso es la clave. Y las nuevas guías del infarto de la europea lo van a dejar muy claro, que eso va a ser lo que tiene que... Y tu approach final de intentar hacer algo simple, no algo que sea muy complejo. Y en ese sentido... Porque no has mencionado mucho, pero todo el mundo casi siempre estamos hablando de los scores. Al final los scores están muy bien, pero la aplicabilidad práctica, bueno, a veces no es tanta y uno se mueve por intuición. Pero es claro que por intuición en el bajo riesgo de sangrado o isquémico incluso solemos sobreestimarlo, y en el alto solemos infraestimarlo, y ese es un problema también. ¿Tú crees que los scores tienen aplicabilidad, sobre todo el PRESIS-DAPT, que es quizás el que más, el nuevo del consorcio ya ha propuesto uno nuevo, el número de 25 del PRESIS-DAPT como tal?
A mí el PRESIS-DAPT no me parece que va a ser un buen score, porque I'm going to speak in English because it's easier for me. I don't think this is going to be very applicable. Well, it is a little complex, actually, and I don't think that you're going to do it when you have the patient in front of you. It's not because it's 24 and not 25 that's going to make a difference, right? We're talking about continuous variables of risk. So when we try to put it into dichotomy, yes or no, it's going to be really hard to decide. But I do think that we have to keep in mind what are the main risks of bleeding. And so this score, the ARC score, is a very good score, also very complex. But if you have in mind that image that I showed, which is the fragile patient that has anemia, that has already bled, that has been transfused, these are the patients you don't want in any way to have a very high intensity dual antiplatelet therapy because they're going to bleed. The thing is that when you look at the scores, even in the ESC guidelines, they have a 2B indication. And that is because the area under the curve is always around 0.7. So they're not very good. They're moderate predictors of bleeding. That's why I think scores, we find a very, very good score, like when you use the GDF-15 to use in the scores in anticoagulation, which work perfectly and increase the prediction of bleeding. Either you use other biomarkers to try to improve the prediction risk. These scores that we have are not very, very effective. But yes, I think you're right when we tend to overestimate the ischemic risk and underestimate the bleeding risk. And that is a problem because it makes us put the patient at risk of bleeding.
Yeah, but I think it's a critical point in clinical practice for personalized, because the risk is the bleeding risk. Obviously, at least in the first 3 months, and particularly in the first month, the ischemic risk. But after 3 months, the ischemic risk, at least in stable patients, is very low. But the problem is the bleeding risk. And the bleeding risk during the first 3 months. I think the problem of bleeding risk after 3 months is not so obviously is relevant if you bleed in the brain or whatever. But the problem is if you bleed during the first 3 months, because the ischemic risk remains very high risk. Because if you put several stents, the stent thrombosis remains to be high. Yeah. And in these patients, so I think it's critical how to personalize the bleeding risk during the first 3 months after ACS or in patients submitted to PCI. So you can do a semi-quantitative approach, as you said, because it's easy to do, because my patient is fragile, is older, have a previous bleed or has a previous transfusion, or so on. But I think this is a gray zone that needs to be how to do in this gray zone. Because I think the critical point is the bleeding risk. So is the reason why is when you don't know how to do, the solution is doing a score. But I think despite this is a continuous score with several variables, with several points in the DAP, should be at least in the gray zone. No, we have a new score that was presented in the past ACS Congress. This is the consortium, but I think it's more complex despite
it is. It has all those variables that I showed. It is more complex to I think it's better as a score, but it is more complex to quantify. Yeah. But anyway, I think the thing here is that what would be wonderful is if we started we have a patient that is admitted for an MI and we do a PCI, and then we should be able to do any kind of reactivity test after, if you want to start with clopidogrel, and you should wait for more or less 2 weeks and then do the reactivity test. And if you have high reactivity from the platelets, probably you should escalate. And if you don't, you should keep on clopidogrel. But this is not doable. I mean, we're not going to do that in the real world practice. So we have to have a scheme that is easier to perform. And that's why I think that this idea of having, for those that are not at high bleeding risk, the possibility of doing dual antiplatelet therapy with ticagrelor for 3 months and then starting just with ticagrelor for the rest of the time, it seems very appealing. And probably if we start looking at this other trials that are coming, which are using for the rest of the time ticagrelor 60 and not 90, maybe we're going to have the right balance between ischemic risk and bleeding risk.
Yeah, it's more or less the Pegasus strategy.
Yeah,
That's the
exactly.
escalation of ticagrelor. I agree, but the problem is this point, how to evaluate, assess in clinical practice the bleeding risk, particularly the high bleeding risk, taking into consideration that the great majority of our patients is high bleeding risk patients in practice.
Definitely.
But the real challenge is how to identify such patients and how to manage DAPT for how a long time with TICA, with CLOPI, regarding not only the bleeding, in these cases regarding the ischemic risk, because also take into consideration particularly stent thrombosis in such patients. So I think it's a fascinating, we're waiting for the ESC STEMI guidelines, that is the next guidelines in the next August, and we will see. But I think we have to, and in these situations, what is your protocol in your clinical practice, in your hospital? Is the protocol you propose?
No, not yet. Not yet. We're doing the vast majority dual antiplatelet therapy for 12 months with ticagrelor. That's the way we go. We do have clopidogrel for those that are older and frailer, or that we feel because of this anemia or other comorbidities like chronic renal disease and also low platelets. We do clopidogrel for those. And actually, the decision about doing short-term DAPT or long-term DAPT is in the visit with the cardiologist afterwards. So we're not deciding that at that moment, of course, because this is a dynamic decision. I mean, you cannot decide at the moment of discharge who is going to be prolonging and who is not, because you never know what's going to happen afterwards. And you have to realize that in the first year, it's when they bleed the most. So the ones that are not bleeding in the first year, those are the easy ones, because they usually actually try to, you manage the bleeding there and you choose the ones that are not bleeding. And afterwards, if you want to prolong, most of the times you can prolong because those are the selected ones. So I would say that the point here is going to be these first 3 months. This is the hard decision. This is where you're paying a lot in terms of bleeding risk and ischemic risk, because if you have to stop antiplatelets there, you're going to have stent thrombosis. Patients are going to die from ischemic events. So it's really important to make a decision there. And afterwards, I think that although you have a lot of choices, it's easier to decide. So the first 3 months are going to be the ones that...
I'm convinced that we need more information and more evidence regarding the safety and the efficacy of maintaining only single antiplatelet with ticagrelor, at least with the low dose of ticagrelor 60, regarding there are at least 2 major clinical trials ongoing.
I only think that the problem here is that most of the shortened duration of DAPT were performed for companies that were actually trying to sell their drug-eluting stents.
Yeah,
So they were trying to see, to make us see that their stents are very safe, they're wonderful, you can stop dual antiplatelet therapy because they're not going to have stent thrombosis. And then they design trials which are small and actually go for non-inferiority, and they try to always look at bleeding, and they are not powered to see ischemic events, and especially ischemic events, stent thrombosis, because, well, they're very serious, but they're not that frequent. So it's hard to see that. That's why meta-analysis can help us. But then again, you're meta-analyzing data that is very different between trials because trials have different durations of shortening of dual antiplatelet therapy. So we really need like a mega trial with 20,000 patients that can actually answer this, if we can or not diminish the intensity of antiplatelet therapy in these first 3 months. And until we do that trial, and it has to be a really pragmatic trial and done by investigators. So for the academics, until we do that trial, we're not going to have the right answers.
Yeah, for sure. At the end, this is business regarding stent companies, pill companies, regarding shortening that, prolonging that. But at the end, the patient is the most important. And in this case, is needed to personalize with experienced clinician that made the decision how to manage in the acute phase. And as you mentioned, is needed an appointment of the patient after discharge because this is a dynamic risk and is needed to decide. But I think that in the future and the new STEMI guidelines probably recommend this strategy of shortening depth in most patients, at least in patients with heart bleeding risk, that is the vast majority in this case, and then maintain single antiplatelet drug with ticagrelor, probably in a near future. But this is our strategy. The vast majority of our patients without bleeding and without excess of bleeding risk, we maintain double antiplatelet for 1 year at least. ¿Alguna pregunta? Yo creo que es un tema fascinante. Y además va a haber nueva evidencia, veremos qué pasa con las guías europeas de STEMI, que son ahora en agosto, y va a haber nueva evidencia, pero es claro que el riesgo de sangrar es el que tiene que dirigir toda nuestra orientación o gran parte de nuestra orientación, porque lo peor que le puede pasar a un paciente es que sangre, porque entonces también puede ser una oportunidad, pues se vio en el Titron que los que sangraban un poco descubrían cánceres digestivos en estadios precoces y sangrar a veces es una oportunidad porque has sangrado, si no, no sangrarías y te descubrirían el cáncer mucho más evolucionado y que sangres. Hay que verlo también como una oportunidad de diagnosticar cánceres y eso se ha visto en el Tritón con Prasugrel, que fue realmente importante. Se descubrieron muchos cánceres en estadios iniciales porque el paciente sangraba y si obviamente sangras, casi siempre sangras por el digestivo, salvo que tenga sangrado intracraneal o otro tipo de sangrado. Realmente, Cristina, si alguien quiere hacer algún comentario, yo creo que es un tema que nos afecta a todos en el día a día porque todos vemos pacientes isquémicos, ahora también qué hacer en la TAVI, que está un poco por resolver, qué hacer con el tratamiento antitrombótico, es también muy problemático porque ahí el problema de nuevo es sangrar, el problema grave es sangrar y yo creo que es un tema que ha estado parado un poquito de tiempo estos 2 o 3 últimos años, pero yo creo que ahora va a volver a renacer, al menos con los resultados de los ensayos clínicos, el último, el Master DAP, bien es cierto que es en pacientes más estables, con un stent que yo creo que vale para todos, pero han utilizado un stent, que es el Ultimaster, y entonces para vender el stent Ultimaster en realidad es para vender un stent, pero eso probablemente aplique al resto de los stents, pero el stent, el que ha hecho el estudio es una compañía que quiere vender un stent determinado y decir, con mi stent no se preocupe, usted puede acortar la doble antiagregación, que no le pasa nada. Creo que este tipo de estudios son un poco...
Pero entre 24 y 26 van a salir todos estos estudios y ahí sí vamos a tener otras...
Y lo que piensa la mayoría es que vamos a ir a una estrategia de DAPT reducida, 1 o 3 meses, en función del riesgo de sangrado. Ya veremos cómo hacerlo, si hay que utilizar un score automatizado o sea semi-cuantitativo, el clínico, la evaluación clínica, y luego yo lo que estoy convencido es que después de 3 meses se va a imponer una estrategia de simple antiagregación, habitualmente de escalada con ticagrelor 60. Toda la evidencia va en esa línea y ojalá sea, porque eso lo hace simple, no toda la complejidad de si subir, si bajar, si descalar, si no descalar, que es al final un lío. Realmente es un tema fascinante para todos y para cardiólogos clínicos, por supuesto, porque lo tenemos que hacer cada día en nuestra práctica. Ha sido un placer
Bueno,
tenerte
gracias.
aquí, moito obrigado. E xa sabes, Porto e Santiago prácticamente, non sei se Porto é un barro de Santiago ou Santiago un barro do Porto, pero ao fin o noso aeroporto xa é o aeroporto de Porto e bueno, aquí pois ao final temos que incrementar esa relación porque somos a mesma cultura, mesmo, quase a mesma cidade agora. Por tanto, moito obrigado.
Que agradeço.
Muy bueno.